Welcome to Pulse and Pressors, where critical care gets crystal clear. High-Risk PCI refers to percutaneous coronary interventions performed in patients with complex coronary anatomy and unstable physiology who lack adequate surgical options. These procedures require advanced planning, precise execution, and often mechanical circulatory support because even short interruptions in coronary flow can lead to hemodynamic collapse. Understanding the patient's underlying physiology, coronary territory at risk, and reserve capacity is essential before proceeding. Patients are classified as high risk when coronary anatomy, ventricular function, or comorbidities substantially increase the likelihood of instability during PCI. This includes left main or proximal LAD disease, complex triple vessel disease, last remaining vessel perfusion, severely reduced EF, and chronic total occlusions, particularly in frail or elderly patients. These characteristics define a population where procedural stress can overwhelm limited cardiac reserve. Hemodynamic risk escalates when the left ventricle has poor contractile reserve, when right ventricular dysfunction limits forward flow, or when significant valvular disease or pulmonary hypertension increase afterload. Patients who are hypotensive or in early shock are extremely preload and afterload sensitive, making them vulnerable to even modest drops in coronary perfusion pressure. Identifying these physiologic risks determines whether support is mandatory before PCI. Anatomic risk factors include lesions involving the left main bifurcation or trifurcation, osteal disease requiring precise positioning, large side branch jeopardy, and heavily calcified lesions requiring atherectomy or intravascular lithotripsy. Long diffuse disease, complex bifurcations, and CTOs further elevate risk. These lesions pose technical challenges that prolong balloon inflation or require multiple steps, increasing the chance of transient or sustained no flow. Mechanical circulatory support should be planned before beginning PCI whenever anticipated coronary flow interruption could destabilize the patient. Situations such as severe left ventricular dysfunction, left main interventions, atherectomy in major vessels, or unstable chronic total occlusion attempts often demand preemptive support. The key principle is protection before collapse, recognizing that waiting until hypotension develops leads to worse outcomes and emergent rescue scenarios. Selecting the appropriate mechanical support device depends on the anticipated physiology. Impella provides forward flow and unloads the LV, making it ideal for left main and proximal LAD disease in patients with low EF. The IABP offers modest afterload reduction but minimal forward flow. ECMO provides full cardiopulmonary support but increases afterload unless paired with LV unloading. Tandem Heart offers high-flow support via left atrial drainage and arterial reinfusion, useful when stronger flows are required. The High-Risk PCI algorithm begins with defining coronary anatomy through angiography and understanding physiologic reserve through echocardiography and hemodynamic data. The clinician predicts where collapse may occur and whether a lesion mandates flow protection via MCS. Once support is instituted, PCI is executed with a clear plan for lesion preparation, stent delivery, and side branch protection. The algorithm emphasizes anticipatory management rather than reactive response. Physiologic management during high-risk PCI focuses on maintaining coronary perfusion pressure, preventing prolonged no flow during balloon inflation, and supporting forward LV output. RV support becomes critical during RCA interventions, where RV ischemia can cause abrupt hypotension. Continuous monitoring of lactate, perfusion markers, and ECG changes ensures early detection of ischemia or impending shock, allowing rapid adjustments in support levels or technique. Atherectomy, rotational or orbital, is frequently required for severe calcific disease, but carries a high risk of slow flow or no reflow due to distal embolization or microvascular dysfunction. In left main or proximal LAD atherectomy, hemodynamic collapse is common without mechanical support. Adequate preparation, short runs, and controlled burr speed minimize instability. Atherectomy should never be performed in high-risk anatomy without prior hemodynamic planning. Intravascular lithotripsy, IVL, provides calcium modification through acoustic shock waves that fracture calcium with less hemodynamic compromise compared to atherectomy. IVL is particularly useful in ostial LAD, or left main lesions, where device bias or burr-induced slow flow poses a risk. IVL often preserves more stable coronary perfusion during inflation, though clinicians must still anticipate temporary reductions in flow during balloon inflation. Intravascular imaging with IVUS, or optical coherence tomography (OCT), is mandatory in high-risk PCI because it defines lesion severity, calcium arc and thickness, stent landing zones, and vessel size with precision that angiography alone cannot provide. Optimal stent expansion reduces restenosis and thrombosis risks. Imaging also confirms whether atherectomy or IVL has sufficiently prepared the vessel, ensuring that stent underexpansion does not become a cause of acute or subacute failure. No reflow is a major risk in high-risk PCI, particularly after atherectomy, ballooning of degenerated plaques, or long stent segments. Management requires immediate pharmacologic intervention with agents such as adenosine, nitroprusside, or verapamil delivered directly into the coronary artery. Aspiration may be necessary for thrombus burden. Mechanical support stabilizes systemic perfusion, while microvascular flow is restored. Procedural success in high-risk PCI is defined by restoration of TIMI, 3-flow, resolution of no reflow, adequate stent expansion on imaging, and stable hemodynamics throughout. The patient should demonstrate preserved perfusion markers and an absence of new ischemic ECG changes. Before terminating the procedure, the operator verifies that support devices remain functional and that no further coronary lesions require immediate attention. Weaning from mechanical support requires assurance that the patient can maintain adequate MAP without vasoactive agents, stable left ventricle outflow tract VTI on echo, decreasing lactate, and absence of arrhythmias. Hemodynamics must be reassessed after reducing device support, ensuring the heart tolerates increased workload. Premature weaning risks recurrent shock, ischemia, or acute heart failure. Immediate post-PCI ICU management focuses on early detection of stent thrombosis, recurrent ischemia, arrhythmias, bleeding, and shock. Close monitoring of preload, afterload, and ventricular performance is essential, especially when MCS remains in place. Anticoagulation, dual antiplatelet therapy, and vascular access site management are critical. The first hours after high-risk PCI carry the highest risk for abrupt deterioration. Complications in high-risk PCI include cardiogenic shock, perforation, acute stent thrombosis, severe no reflow, and RV failure, particularly after RCA interventions. Perforation requires immediate covered stent deployment or pericardiocentesis if tamponade occurs. Shock management is MCS-driven, and early recognition prevents multi-organ dysfunction. These complications emphasize why high-risk PCI must be performed with anticipatory strategy rather than reactive rescue. The key principles of high-risk PCI are anticipation, protection, and precision. Collapse must be predicted before it occurs, mechanical support instituted early, imaging used to guide every step, and physiology monitored continuously. When these elements align, even the most complex anatomy and fragile physiology can be managed safely. High-risk PCI is not defined by stent placement, it is defined by preventing hemodynamic failure. This is Pulse and Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.